All right, we're going to go ahead and get started. Thank you to everyone who's attended. We're excited about today's presentation on the implementation resources through HRSA's Federal Office of Rural Health Policy. My name is Shannon Robshaw. I'm with the TA Network for Children's Behavioral Health, and I lead staff along with Sarah Warner for the Rural Behavioral Health Learning Collaborative. I would ask those that are not speaking to please mute their phones. We're getting a little background noise. So if you could just keep your phones muted until it's your time to present, that would be appreciated. Thank you. But welcome to everyone that's joined today, and if you had, we would welcome your feedback on this presentation. You can contact either Sarah or myself directly at our email addresses. We're also going to have a survey available at the end of the webinar. We would ask you to please take just a couple of seconds and click through that. It won't take very long at all. We really would appreciate your feedback. We're also soliciting requests for future webinars or PowerPoint presentations, speaking presentations. So please, if there's a particular topic area that we have not addressed yet through this forum that you're interested in, we would welcome any suggestions from you on that. So let's find out today who we've got on the line. I know we've got we haven't got our full cadre of folks on the line that have registered. I expect more people will be joining as we move through the presentation, but let's see who we have right now. So just try to click on which best describes your organization. We'll know who we're talking about, who we're talking with here. Providers, federal agencies, state, territorial, local health agencies, others. We've got a lot of other. We don't know what that is. We need to figure out different categories to add in so we can capture who everybody is. Anybody else going to sign on? All right then. So let's end the poll. People can see how they've identified themselves. Oh, nonprofit advocacy organization. Maybe, Tiara, we can remember to add that in going forward. Jenna with the Carlson County Restorative Response Department and Miracle. So, yeah, nonprofits, and that's really a good one to add. All right, so your role can best be described as. Please click the ones that's closest to what your job duty is. Just another few seconds. There's to one year. We get a sense of who we're talking with. All right. One more second, and I think, Tiara, we can probably close the poll. So we have project directors, executive leadership, TA providers, direct service providers, and other. All right. All right, then, that's interesting. Well, it's always helpful to know. Policy analyst. Thank you, Kyle. So thanks for sharing that information with us. It's helpful to know who we're talking with. So now we're going to move right into the presentation, and let Carlos Munoz started off. He's with the Federal Office of Rural Health Policy, and we thank you again, Carlos, for coming and presenting this information, also for organizing the grantees that will be presenting after you for gathering their information and bringing it to this group. So thank you. And Carlos, you want to get started? You need to unmute.
Okay, I'm unmuted. Great. Okay. Hope everybody can hear me okay. Thank you, Shannon, very much for the introduction. And welcome, folks, to today's webinar. I'm Carlos Mena. I'm the program coordinator and also project officer for the Telehealth Network Grant Program, which is housed in the Office for the Advancement of Telehealth, which is a division by statute, and it's also in the Federal Office of Rural Health Policy. that's housed in the Health Resource and Service Administration Agency, which is one of 13 operating agencies in HHS, along with our sister agency, SAMHSA. And so I'm going to be giving you a background about the office, the Telehealth Network Grant Program, and I'm very happy and excited to also introduce and hear about 3 of our prime recipients in the cohort who will be speaking to you about their respective projects. They're the boots on the ground folks for Kentucky, Indiana, and Washington State, so pretty exciting stuff coming up. And so just an overview about the Health Resource and Services Administration. We support over 90 programs, grant programs, to serve the safety net communities and rural communities across the country with about an annual budget of $10 billion that goes out in grants every fiscal year. And the Federal Office of Rural Health Policy is authorized in Section 711 of the Social Security Act, created in 1987, and really focuses on rural policy issues, supporting rural communities through various grant programs. The Office of Advancement of Telehealth actually joined much later in 2010. The administrator of the agency has discretion to place us where the highest need bureaus and offices throughout HRSA is. And so the office was actually created formally by statute in 2002, the Office of Advancement of Telehealth, and placed in the Federal Office of Rural Health Policy in 2010. And this is our organizational structure, and as you'll see on this slide, the bottom there, bottom middle is where our director, Dr. Bill England, who heads the office. So our office supports close to 250 rural communities through various grants to test out ideas on improving access to services, coordination of care models, and many of the lessons learned from those projects can be found on the Rural Community Health Gateway via the RHI Hub website. So I highly encourage folks in the audience to simply Google Rural Community Health Gateway to find a number of models that have worked. There's evidence base for them, toolkits and resources that can help folks in rural communities if you're interested, particularly around behavioral health. And so the Telehealth Network Grant Program is one of the largest grant programs that is administered through the Office of the Advancement of Telehealth. The grant program can actually be found in Section 330 of the Healthcare Safety Net Amendments Act of 2002, separate from the 711, Section 711 of the Social Security Act for the Federal Office of Rural Health Policy. This program supports established networks to help increase delivery of badly needed services for rural populations. And since its inception, when it was first appropriated in 2006, we've seen that telehealth maturity has evolved and providers and patients have become accustomed to telehealth. The range of services and providers addressable by telehealth has also increased. And although the static cost of broadband and technology has decreased, the quality and capability of technology is increasing exponentially, as you may have heard in various news outlets. And so the cost of broadband and technology and the need to update technology remains a barrier to new entrants. But in addition to the emphasis to utilize telehealth to train healthcare providers, that has led to many Project Echo models that are now becoming an important aspect of remote practice, which HHS will soon report under the ECHO Act. The report is due for release later this year. And Project ECHO standing for expanding capacity for health outcomes, so sort of utilizing telehealth for providers to expand their knowledge base from specialists at a distance. So experience from these grants is generally expected to have broad application by identifying best practice models that can then be adopted at state or local levels for the ongoing care of patients. We'll be getting a little bit more into that pretty soon and how delivery of telehealth into rural schools is impacting kids. And so one of several neat highlights of the program is that fiscal year 2017, the current cohort of 21 recipients saved 1.6 million patient travel miles saved for rural populations, and that was highlighted in HRSA's 2017 Year in Review infographic that can be downloaded off the website, HRSA website. So if you multiply that by the General Service Administration mileage reimbursement rate of 55 cents, we find that approximately $880,000 in savings for that 1 year. We also take into consideration that it does not factor in the saved time of a patient not having to miss work or a child missing school for even more savings. So our current cohort just began its third year of a 4-year project period, and it's the first time we support rural schools as a setting and children as a target population as a result of various prominent reports that were published on disparities in healthcare among rural children. In previous cohorts, this grant program traditionally focused on all age groups with a particular emphasis on COPD, chronic heart failure, diabetes, and other disease management services. As mentioned earlier, there are 21 recipients that are working across 19 states. So I'm excited to hear 3 of them in our cohort soon. And so why telehealth in schools? And as you see on this slide, these are some of the key reasons, especially in that it helps parents who work 2 to 3 jobs keep them from leaving work. And benefits is that parents still remain the driver, and some schools even offer adult care after school hours. And this is a list of our 21 recipients, again, across 19 states. There are actually 2 in New Mexico and in Tennessee. And on the map on the left shows the states highlighted in green that where Medicaid actually reimburses schools as a healthcare setting. The map on the right shows the states highlighted in blue where this grant program is currently operating. Only half of the states in our cohort reimburse schools as a setting through, or the Medicaid state office actually reimburses schools as a setting. So this is a really nice incentive to have this grant program for most of our recipients, and seeing what kind of cool outcome data can be achieved from utilizing telehealth for providers and kids at these rural schools, and providing this information to state legislatures and policymakers. So as with every grant program and government, evaluation is a priority. So in September of 2016, when the project period began, we partnered with HRSA's Rural Telehealth Research Center to develop some highly valuable yet common metrics that we could apply to this grant program to measure its impact over time. Most of our grantees have been very open to this evaluation and have collaborated extremely well in this effort to make sure we're going to capture the right data to show if telehealth is effective in rural schools. A lot of progress has been made to date, with 90% of our grantees submitting DUAs and IRBs to be issued to each one of them this fall, and then some pilot testing of the measures with the final data collection process to begin on January 1 of 2019. We whittled it down to 27 measures that our recipients will be reporting on, and this was after several rounds of scoring of over 1,000 peer-reviewed measures in the telehealth and pediatric world. The Rural Telehealth Research Center and grantees had gone through various rounds of scoring to whittle it down to the 17 clinical measures across these 5 priority clinical domains and also 10 non-clinical measures. And here's a sample of 3 behavioral health measures. Federal Register notice were shared for public comment on all of the measures, and they are currently in the final phase of review by the Office of Management and Budget. This is a neat resource. If folks aren't aware of the School-Based Health Alliance, they do a lot of work with a lot of schools across the country in getting schools set up as a school-based health center. So if any of you in the audience are in that field and have particular interest on these categories, we do encourage folks to visit that website. Another grant program, or one of our gems, I should say, in out of the 9 different grant programs that the Office of Advancement of Telehealth manages, is our telehealth resource centers. And we certainly like to promote them in our webinars and conferences for folks to reach out to them if you have any question on telehealth. So whether it's on policy related for your respective community or state, equipment, trying to identify what's the best piece of equipment to purchase for treating dermatology, for example. These are our folks. There's 12 regional and 2 national. One out of the 2 national, one focuses specifically on technology, the other on national policy issues, also state. They actually do some state work. And so they do offer actually free technical assistance to any active HRSA grantee. That's part of their grant requirement. And again, any questions, telehealth, please visit that website for more information. And last couple slides here. We do send out weekly announcements, the Federal Office of Rural Health Policy. And so if you're interested in learning more about the latest grant opportunities that are available, sometimes there's some special editions of these weekly announcements that will be sent out. Listing a grant announcement that just came out. There was a month ago, there was one on opioids and another one on behavioral health or telebehavioral health, I should say. So please email my colleague, Ms. Daniels, there on the bottom if you're interested in receiving weekly updates. This is my contact information. And there's our website, so thank you. And I think Chris is up next from Baptist Health Corbin Foundation, as well as his colleague, Lee Richardson. So thank you, folks.
Thank you, Carlos. I think we'll move right into the next presentation and try to save general questions at the end. We'll have a couple of minutes at the end of each of these next 3 presentations on these particular programs where we could take questions and also try to have questions again at the end. So Chris, welcome. Thank you for being here. You want to get started?
Excellent. Thank you. Can everyone hear me okay?
Yes.
Okay. All right. So I would like to go ahead and start out by saying, thank you, Carlos and Shannon, along with your team, for organizing this educational opportunity. I'm very excited to outline how we've been able to increase access points and reduce consumer cost. For all those listening, good morning or afternoon based on your location. Again, my name is Chris Holcomb, and I'm the Executive Director of Behavioral Health and Telemedicine Services at Baptist Health Corbin. With me, I have Lee Richardson, and she is the Director of our foundation and oversees all grants. Say hello.
Hello.
Apparently, I lost a bet, as I will be the primary speaker, but I can defer some of the questions possibly at the end of the presentation to Lee. I want to start out by giving a background of our hospital. We are located in rural southeastern Kentucky, an area that has been historically plagued with poverty, drug abuse, premature mortality, and a lack of medical specialists to meet the demand. However, we do live in a region that is very resilient, with many positive things occurring and on the horizon. At Baptist Health Corbin, we are lucky to have the full support and be embraced by our senior administrative team. This is a unique hospital in that we have valued and first initiated behavioral health services in 1974. So we are the oldest and longest tenured hospital in our state network with inpatient and outpatient psychiatric services. I'm very proud to speak of our robust service line, which consists of 2 adult inpatient psychiatric units. We have an inpatient adolescent program, as well as an inpatient adult medical detoxification unit. To complement those acute programs, we offer step-down services, which include an adolescent partial hospitalization program, a chemical dependency and mental health intensive outpatient program, and a traditional on-site outpatient clinic staffed with licensed therapists, psychiatrists, and nurse practitioners. Part of our strategy has been to embed behavioral health services into our primary care practices to reduce the stigma and reduce the transportation and associated costs for our patients. I will go ahead and discuss a little bit more about that later in the presentation, though. So starting out with a question that many of you might have as to why did we actually decide to include and incorporate telemedicine services in our service line. Well, we've been blessed to actually have a great group of visionaries, and I think all of them would have very unique answers to the question as to why. But for me, it was through trial and error of working as an outpatient therapist in one of our clinics providing individual and family counseling, and that was about over a decade ago. At that time, I would primarily see a lot of adolescents that had a mood disturbance, depression, anxiety, or kids with drug and alcohol issues. I noticed that most of them would come to see me and then get a school excuse while never going back to school that day. The resultant trend was that many of the kids fell behind academically, which only made worse the primary problem. I recall doing a presentation for the local school board on self-mutilation, and the topic came up about how they were frustrated that many kids saw outpatient treatment, which in many cases negatively impacted their academic standing by failing to attend class on scheduled appointment days. My response was that I had also observed that and noticed that trend, and I had the same question. But I actually kind of felt like the school officials were blaming the mental health field. While I also wondered if the schools were at fault for possibly being insensitive to the emotional troubles facing our youth. All in all, it turned out to be a great discussion, which led me to wanting to find a better solution for all. As the years went by, I learned more and more about telemedicine, and it finally hit me that this was likely the solution to give teens the much-needed professional services while minimizing lost student time in the classroom. We decided to assemble a work team for further discussion. We decided to apply for some telemedicine grants because we wanted to be on the cutting edge of providing services while reducing barriers for the patient, including lost wages for parents, transportation costs, etc., which I believe Carlos mentioned earlier in this presentation. As you look at the second slide, after we started pulling up a work group together, we opted to apply for 3 grants over about a year's time. We hoped to be awarded one of them and very fortunately received all 3. Baptist Health Foundation is the one that oversees our grants, and Lee and I work closely together on all of the grants that we currently have going on at this time. Our first 2 grants were DLT, which provided the funds to purchase equipment, and the third and the largest was a HRSA grant to provide more equipment, employees, and training. Forming community partnerships helped to showcase that our goal was to improve the quality of care and to promote freedom of choice and provider selection. I wanted to focus and prioritize quality over quantity and start slowly to work out the kinks that would unavoidably arise. We received our equipment, and you can see that we went with Polycom and have been very pleased. We utilized the utility cart and the group convene in all our locations. We have great plans for the Centro for remote group therapy and conferencing. We recently stationed the Centro in the middle of the vendor room while we had a behavioral health and telemedicine symposium, and it allowed the vendors to watch the presentation in real time while desensitizing the audience to the great possibilities of its use. Just prior to our go live and after obtaining the stamp of approval to be a member of the Kentucky Telehealth Network, we shifted our focus to the patient entry. Always in clinical services, the patient must be informed of their rights, and we obtain informed consent. Our blanket initial statement was pushed up to our legal team, who then made one suggestion to add, though. They wanted an attestation comment in each clinical note to highlight that the patient had been made aware of the service and the right to refusal, along with additional language. You can actually read that as I continue talking. But why would we do this? Well, aside from the ethical obvious, it would help us to prevent and reduce billing and coding errors to alert them to add the required modifiers of GT as necessary to show it was a telemedicine service. That has actually been very beneficial for insurance reimbursement, as we've had few overall denials. Once we had developed a network including educational partners and looked at the details pertaining to coding and billing, we went ahead and launched our services with South Fork Medical Clinic in an adjacent, more rural area. After installation of the equipment and prepping for the go-live, we started providing psychiatric initial evaluations and medication management. Most of the folks had to previously travel in excess of 1 to 2 hours before, but this helped to emphasize our old hospital slogan, which was quality closer to home. So now here we are, we're getting ready to really launch and grow much bigger, and baby steps before walking. We were ready to begin our slow expansion after SEMA to analyze most details. 7 months ago, we started services with an independent private counseling practice in town, and that has been very successful and continues to grow. Then in the same month, we also launched our first school-based telehealth service in such a meaningful area which maximized savings of countless dollars. This will be the program and the service of that I will highlight in a couple of minutes. 3 months later, we added an additional provider, therapeutic foster care, to better meet the needs of providing services in a rural area. If you look at our year-over-year monthly comparison chart, you can see that we have expanded the number of visits greatly. The more impressive aspect is that we are just now really starting to see exponential growth. Some reason as to why include increased provider time and massive demand. I project that we will be over 100 visits monthly by the end of the year and over 200 visits the end of March 2019 based on additional partnerships. As I alluded to earlier, one of our initiatives prior to telemedicine pursuit was to embed and integrate behavioral health services into primary care to reduce the stigma of seeking treatment while providing additional access costs. We have been successful with the behavioral health integration into our 3 primary service area locations. Telemedicine has allowed us to really increase various access points. For the purpose of today's presentation, as you can see on the slide, we wish to highlight one such primary care clinic and its partnership with a group home in that same community. This creative partnership helps to showcase the value of telemedicine services while reducing the numerous barriers that have plagued residential facilities for quite some time. So really want to look at the creative partnership with Appalachians Children's Home, as this is an atypical view of school telehealth, but one that is very impactful for the teen, school, and facility. This is thinking outside the box when it comes to assessing telemedicine services in a unique school-based setting. So Appalachians Children's Home, what is it? Well, it's a faith-based group home for adolescents. It's situated on a very large campus, as you can see, 158 acres. It is located about 30 miles from our main hub at Baptist Health Corbin. It's a state licensed treatment facility, emergency shelter, foster care, placement agency for boys and girls under the age of 18. Many of these individuals have depression and anxiety and have not been able to maintain in the community. Therefore, they go to this facility where it can be anywhere from 6 months to a year and sometimes longer. So going back to my outpatient therapy time, one experience stands out. I was a therapist for a few of the teenagers actually from the children's home, and they would be brought about 30 miles from the campus to our facility by a group of direct care workers. As many of you have experienced, it can take a fairly long time waiting to see a primary care physician or a specialist, and that increases frustration. And also in this case, it incurred a lot of additional staff costs. Anytime a teen is removed from a secure setting, it increases the chance of elopement. It also requires additional staff for monitoring, not to mention bus and gas associated expenses. On one such occasion, I recall a teen running out of the clinic, which really caused a commotion, and it led to hospital security having to intervene and others attempting to locate the runaway. Fortunately, we were able to go ahead and catch the teen, but just prior to him running out in front of a car that almost led to an accident. Once we secured the HRSA grant, we decided to meet with the Children's Home administrative team to discuss a partnership. During that meeting, we were asked about the then challenges and barriers to seeking off-site psychiatric treatment. And some of the responses that came from that meeting was that taking multiple students off-site require at least 2 staff, also having backup staff at the school and home. Definitely an added cost to the program. And this is one area that the Children's Home staff has talked about, that it's greatly reduced the expenses for them, and being a nonprofit, it's allowed them to utilize that money in different ways to further benefit the teenagers that are there. The nearest provider is 20 to 30 miles away, meaning that's an hour or more of travel time to each appointment. In addition to the cost of staff, there's also the cost of transportation. Students miss countless hours of class time, preventing them from gaining credits and being successful in the classroom. And then you have the risk for elopement is greater, as I alluded to earlier, when students are taken off a secure campus, especially those who are new and have not had an appropriate assessment or medication management. Once we went ahead and looked at the current state and the challenges that had been identified, then we discussed the possible benefits for the facility. And some of those at that time was that IT support would be available from the IT department for any issues that may arise with the telemedicine equipment. The Telemedicine Navigator is available for request for appointments, medication refills, as well as billing and insurance question. The Navigator plays a huge critical role because essentially they are the gatekeeper, and the staff at the Children's Home can automatically contact that one person who will have access to the schedule and has a blocked off time where we have one single provider for continuity purposes that will see all of the children there. Also, parents and students have access to our helpline, which is a 24/7 helpline that is operated by the hospital. And the facility treatment team is actively involved in the session, which helps to enhance the quality of care. Because of the HRSA opportunity and resources, we have bridged a great partnership with an awesome facility. This program has on-site teachers from the local school district Monday through Friday during regular school hours. When the teens have an appointment with the psychiatric nurse practitioner, they leave class and return shortly as to not miss an entire day. The communication between the two facilities has greatly improved, and I truly emphasize that piece, greatly improved communication. Previously, when the teenagers came to our facility for an in vivo session, the counselor at the Children's Home had to type or write out a letter that was a communication log, which was their policy for a handoff. It would include any other possible medication changes, weekly behavioral issues, or any additional pertinent information the provider should be aware of. Now the nurse, case manager, and therapist can provide the information on the front end of the telemedicine session, and then the teen is seen individually. The Children's Home has reduced staff costs and reduced the risk for AWOLs by not having to remove the teen from the campus, as the teen actually returns back to the class and does not fall behind further academically. It truly is a win for all involved parties. If you look at some of the quotes from the staff, the first one, the students served have reported positive feedback regarding telemedicine services. They indicate it's way faster than going to an actual doctor's office and sitting and waiting. And I think we all can relate to that, as I know when I go to see my primary care physician, then it's not uncommon to be there 2 and 3 hours. The therapists there reported positive benefits, including having more of a hands-on involvement in the services provided and improved continuity of care, as they are able to attend sessions and speak to the service provider directly at each scheduled appointment if desired. The medical department staff report easily resolving any of the technical glitches and great working relationships with the service providers. That's wonderful comments, and very glad to hear that. Now, as you can see, the biggest room in the world for improvement, or the biggest room in the world is for improvement. And we have made a lot of progress, and we are very thankful and blessed to be in the position that we are currently in. However, always room for improvement. And one of those is our hospital recently went with EPIC, which is the electronic health record. Now that is limited to our primary care clinics and hospitals, so it has to be under the Baptist Health umbrella. It would be beneficial if we had signature pads at each of our sites for the patients to sign. However, that would also require them to have EPIC software, which is a costly investment for some of the smaller practices. In Kentucky, there was some recent legislative changes that will go into effect July of 2019, which is really going to open the doors so much, and there are going to be so many possibilities for school-based telehealth in Kentucky. One of the areas that we have been hindered with is that a licensed therapist, licensed clinical social worker, or LPCC could not provide counseling services to the Medicaid population in Kentucky. And in our area, primarily Medicaid is the primary insurer. Now, with the legislative change, that barrier will be removed beginning next year, and it really focused on true parity for telemedicine visits as opposed to those in vivo. Plans for continued expansion. Well, we plan to have a better defined telemedicine hub, which will house the various staff in one general location. As of right now, my project manager, the navigator, the IT individual are like in different locations. And so we come together daily for frequent meetings, but we have a plan in place to put them in one office suite where we can go ahead and expand, and that will be very beneficial for added communication. Also, we are continuing and actively looking to recruit additional providers that will expand different service lines. One of the things that I will have to say in rural Kentucky, and I'm probably speaking for most of rural America, it can be a challenge, very much so, to recruit and retain providers. Telemedicine really has opened that up. I have interviewed various psychiatrists over the past couple of months, and many of them are getting ready to finish their residency. And one of the first questions they ask is, hey, are you doing telemedicine? They very much are interested in the technology, and so that's something that I feel will continue to be a wave in the future and will help us to really grow and recruit additional providers. We also have plans to place a greater emphasis on quantitative and qualitative data collection. I really want to see data pertaining to our primary and secondary service areas that compare telemedicine visits to in vivo sessions, and so that's one of the things that we are looking at as well. I would encourage each of you to utilize your state regulatory body. In Kentucky, we have the Kentucky Telehealth Network, and the president is Rob Spring, who has and continues to be a wealth of knowledge. Without that support, we would not be at our current place and position for exponential growth. So I have to emphasize the importance of utilizing your board. So I would like to thank each of you for listening to this presentation, and we'll be glad to field questions now or at the end of all the presentations. Thank you.
Great. Thank you, Chris. If anybody has questions, please go ahead and type them in the chat box there. We invite one or two questions. Chris, we don't have a whole lot of time. We want to save some time for questions at the end. But can you just in a real shorthand describe how you use the telehealth with the therapeutic foster care?
At this point, great question. We were approached by the Therapeutic Foster Care Agency, and one of the first slides that I said, our first locations was the South Fork Medical Clinic, and that particular foster care agency is located, their headquarters, in the same shopping center as the primary care clinic. So at this time, they are taking their clientele to the primary care clinic to be seen, and they are very hopeful that we will embed telemedicine equipment in their facility, and that way it will prevent them from having to drive. It's about 40 miles away is the closest provider for them. So it's really helping them, but they also would like for the equipment to be placed in their facility.
Okay, so is it a family home, or is it the larger facility, the foster care setting? Do you know?
The therapeutic foster care?
Uh-huh.
Yes, it actually is the regional hub in that location, and on a monthly basis, the foster parents, along with the foster children, have to go to that facility to check in and to go through various training. And it makes it so much easier for them to, in that same day, go ahead and touch base with a psychiatric nurse practitioner, especially if they're on medications, and so they can go, within the same shopping center as opposed to having to travel such a great distance.
Right. That's really fascinating. Well, thank you for sharing all that. Really interesting, and I don't see any other immediate questions right now. So if we're okay, and we'll take more questions at the end, but let's go ahead and move forward to our next presentation. Lisa, you want to tell us about the work that you're involved with?
Yes, I would love to. This is Lisa Crandall, and I am here today representing the Lower Yakima Valley Telehealth Network. And we have been working on the thoughts of getting health care in the schools for quite some time. And then we're, even before this grant, trying to figure out some ways of getting telehealth to make sure that we could access all our kids and they could have opportunities to see. At that time, we were focused really on primary care and pediatric providers. And this grant just came along at a perfect time for us, and we'll talk about that more later, but we've just been honored to be able to be a part of it. So I will make sure I can move my slides. Hey, there we go. So I'll just tell you a little background about the network. We are a consortium of healthcare providers and schools located in the Lower Yakima Valley region. The network includes Astria Sunnyside Hospital and Clinics. It's a critical access hospital and one of the main providers of both acute care, specialty care, and primary care services in the community. Sunnyside Pediatrics, which is a pediatric rural health clinic in Sunnyside, and the John Hughes Student Health Center, which is the only school-based brick-and-mortar student health center in the community, and then the Sunnyside School District, which includes 8 schools. And just to talk a little bit about where we were before the grant, Astria Sunnyside serves the Lower Yakima Valley, and it is an area that's both growing rapidly and very young. We have almost 13%, 23, oops, I'm losing my focus. We only have 8.6% of the population is 65 or older, and over a third of the population is under the age of 18, so we're very young. We're also poorer and less likely to be insured than the rest of the state, and very highly Hispanic. 77% of the service area are Hispanic compared to only 13% statewide. The unique characteristics of the community are also reflected in our schools. There's a significantly higher percentage of students eligible for free and reduced lunch in our community. We have 82% almost versus 45% statewide. And the Hispanic population in our schools is almost 92%. And the other unique part of that is over 13% of them are migrant. So we have some unique population characteristics that we're dealing with. And of course, as the other speaker talked about, and Carlos, there's issues in rural areas overall and some unique to our community around access and affordability, language barriers and employment barriers. With a large migrant population, the parents are often in physically demanding jobs involving long hours and no opportunity for paid leave or flexible hours. So it makes it very challenging for them to leave work and attend to health care needs during the school day. And it also means that they would be losing wages and risking job security in order to come during the school day to take their children to appointments. And also, transportation and communication barriers are huge in our community. Many of the families do not have reliable or consistent transportation. This results in delayed care, missed appointments, rescheduled appointments, delayed medication fills, and other access issues. And also, huge barriers related to communication. Many of the residents, being migrant, don't have permanent residence or telephone numbers that complicate ongoing communication and follow-up. So we also have a very high burden of chronic disease in our community that is impacting the children as well as the adults. We have high rates of obesity and asthma, particularly being in an agricultural community. The asthma rates have been a challenge, and we have many kids that are being treated for chronic conditions as well. So the network actually formed not as a formal network, but it was the school district and the hospital and the clinics in the community knew there was problems with kids getting care during the school day and just having access in general. And so they originally thought they would solve part of this problem, and they did by creating a school-based health center at the high school. And so that was done in 2015. But clearly that did not address a lot of the needs for the younger kids in our community. And so there was a lot of discussion about how can we meet the needs of all the kids in our community. The expense and economies of scale prohibited us from being able to do a health center on each school district site, each school site in the district. And so the network started reviewing other options and looked at a lot of telehealth programs throughout the country that have increased access to healthcare services. At that time, not many of them were school-based, but it was a thought that we could use the providers that had just inherited the John Hughes Student Health Center to be able to provide some telehealth services into the schools. And so we were in the process of trying to determine how to do that when we ran into a barrier. One of our key barriers had to do with reimbursement. So the key providers of both primary, pediatric, and urgent care in Sunnyside, which is the main town serving our community, are rural health clinics. And so the current Medicare regulations do not allow rural health clinics to be the destination site for telemedicine. So this limited the network from being able to establish a financially viable telehealth program in the schools. We had many meetings with the Washington State Healthcare Authority to try to figure out how we could address this. Large portion of our children are Medicaid, not Medicare, but unfortunately the HCA, the Healthcare Authority reimbursement in our state is currently tied to Medicare cost reports and Medicare conditions of participation, which limit this reimbursement. So the network has been in discussions with Healthcare Authority, and they're very interested in trying to develop some solutions. Our state has actually been moving quickly with lots of different ways of enhancing telehealth. There's telehealth parity. Telehealth has been allowed in homes and schools, but this is one area that continues to be a barrier. And so the network is collaborating with a statewide committee to enhance the understanding of health services and in rural areas, and to just really be clear that in most of the rural areas of Washington, it is the rural health clinics and the critical access hospitals that are the safety net providers. And so there is a need for them to be able to provide some of these services. There was some discussion about trying to get some providers outside of the community to do telehealth in the schools, and we just got a lot of feedback from the school nurses and schools that it would be a barrier they could see of parents, especially in our community. It's very difficult to develop trust already, and so it would be strong preference to make sure we're using community-based providers to provide that care. And again, those providers in our community are rural health clinics, are providing care through rural health clinics. So this grant came along at a perfect time and allowed the program to move forward while we're still in the process of working with state and federal policymakers to inform these discussions. So what we originally proposed was to basically develop virtual school-based health centers in each of the 8 schools in the district in order to increase access to both acute care services, so if the children have an injury or illness during the school day, and then also to improve the management of chronic disease for students and families in our community. So our original goal, and we're successful in this, although we changed it a bit, was to place technology in each of the schools in the district, and then to also put it in the primary care and pediatric clinics in order to be able to address the primary health care needs and the chronic conditions. We did, after we got the grant, revisited some of the thoughts we had on technology. We had also looked at the Polycom carts as an option, but as we got into the schools, there was not room for that, and the school nurses were very hesitant to try to have that equipment in their classroom, and so we ended up going with a much downsized version where we have the digital equipment that connects to the school nurses' laptops, and then we have a kind of virtual waiting room that they dial into, and so does the provider. And so it was much lower cost than we had originally anticipated, and much more user-friendly for the school nurses. So we did have successfully placed technology in all of the schools in the district, and all the nurses have been trained on that technology, and it has been a little bit of a long process, but we do have it up and running now in each school. We also have provided training to school nurses and providers. This is one of the things that we knew would be important, and we started off right away with getting into the schools and training nurses and the providers on the equipment and the process. And like I said, they were very involved in the development of what the equipment we were going to use, and we made some big adjustments based on their feedback, which I think was important and has helped them be more bought into the system. We also did develop a system for updating the EHR that would include specific notifications for telehealth visits so that we would be able to collect the data that was needed for the grant. One side note to that is now the hospitals and clinics are going through an EHR update, and so that brought some challenges, but I think will also bring some great successes for the program to having a better, more integrated EHR. We did already have a significant set of policies for the John Hughes Student Health Center that we have incorporated into this larger school health program. But one of the things that we didn't have was a consent form specific to telehealth, and we knew that would be important. So that was one of the first things that we worked on, and I'll talk a little bit later as we get to some of our challenges about that process and how that worked. And then the other thing we really knew was going to be important was to develop communication tools to notify families, the community, teachers, and administration of the program. And we have been very vigilant on doing that, and have also run into some challenges along the way with that as well. I would say just as far as major accomplishments, and just to be upfront, when Carlos asked me to be one of the presenters, I said to him, you know, we've had a lot of challenges, right? Because I wanted to be clear that we're really excited about this program, and as we talk about major accomplishments, there have been some great ones, but we also have definitely run into some big challenges that have slowed down the implementation of our program, but I also believe are leading us to a stronger, better, and more comprehensive program. But I did want to make sure that as we did the presentation, we were really clear that we've had some big accomplishments, but also some bigger challenges than I had originally expected. So our major accomplishments are that we've convened this network in a very much more formal way, and we have established a regular meeting schedule. We started out actually thinking we could do it quarterly, and now we've moved it to monthly because of some of the challenges. And the telehealth network now, those meetings involve the CEO of the hospital, the providers, the superintendent, and the people actually implementing the program, so that we can continue to really have champions that are supporting the program and involved in the day-to-day implementation, and that has made a big difference this last year. We did, like I said, successfully selected and purchased our telehealth equipment, and it is up and running. I equipped all the schools and provider sites. And the parental consent requirement was one issue that we definitely were challenged with. We got the consents sent out to every family in the district, and with marketing materials describing the program and making sure they knew the benefits and that this was a free service and all of that, and we got back a handful of consent forms. And so we did go through quite a process. The John Hughes Student Health Center had already developed a verbal consent process that was approved and moving forward, but that worked for the hospital side of things. But now working with the school district, we needed to spend some time to make sure that the school district was comfortable with the process we implemented. And so that did take quite a bit of time working with attorneys and making sure that we had a process in place that would meet the requirements and make sure that parental consent was obtained. And so we have now established a system of both written and or verbal consent that has worked well for the program, but that definitely was something that took some time, and we are pleased that it's now working well. We also did provide detailed on-site training to all the school nurses and providers, and we continue to do that on a regular basis. When we get to challenges, we'll talk more about the challenges of turnover in a small rural community that has impacted us on all levels, and we'll talk more about that in a minute. And so it means that training and ongoing training is even more important. We also have conducted extensive community and family outreach and education, which has been also a process, but I think that it has really, this last year, been much more positive, and we're getting much more broad community support for the program, which is exciting, and we hope we'll move it forward in a more effective way. We have designed a solid evaluation program. We do have, like I said, we have specific notifications in the EHR that will tell us when it's a telehealth program, and we have ways of pulling that data and running that data to make it pretty user-friendly for us as we're reporting back to the grant. We would love to get more kids and more data into that program. That is definitely our goal this year, is to be able to really implement that program and recognize the differences, be able to report on those. And we are proud of the fact that we continue to be able to adjust the program staffing issues. We definitely came into this, I think, not understanding really how big of a change this was for our providers and just the challenges that would be faced with the support they would need as there was turnover and just changing a whole way of looking at how you provide care. And so we are continuing to adjust and feel like we've made some really great progress in that way. And like I said, we have champions now that are at every meeting and really trying to listen to the people that are boots on the ground and having to implement this. And again, in a rural community, providers are pretty strapped already, and so trying to make sure this is seen as and implemented as something that is positive and not additional work, but really helping them to treat their students and patients better. And then we have successfully treated some students through the telehealth program for acute health care needs. We are still working to get the program off the ground in a more meaningful way for the chronic care patients, and can talk about that more in a bit. The providers have had some concerns initially, and we have worked those out and are moving forward with the program, but just around making sure that families continue to be very involved in the management of their children's chronic conditions. And so we are trying to establish a system that has those initial visits with the provider on site and then be able to do the follow-up visits through telehealth. The follow-up visits are the area where the providers are most concerned with their students or their patients not being able to get back in. It's a big challenge for parents with kids with chronic conditions, and especially working with a migrant population, that there are some huge challenges with them being able to make those follow-up appointments. So we are working diligently to develop a system within the pediatric clinic to identify those specific patients and be able to help those providers communicate directly with the school nurses and get those appointments scheduled in the school setting. And I think we're hoping to kick that off here in the next month or so, where it'll be a much more intentional and directive program that we have, and I'll talk more about this in a minute too. These things all kind of overlap, where we have brought someone on board to really help with some of these issues around coordinating care. So the lessons learned. The unique demographics of the lower Yakima Valley have definitely resulted in some unique issues related to being able to coordinate care. Again, the cultural barriers already exist in trust issues, and so making sure that the parents understand that as we try to implement this new program, it is really a benefit to their students, and that they will still have that contact with the provider that they trust and have built that relationship with. And we believe that this has really actually helped with the communication barrier issue, because now the providers have this much more and much deeper connection with the school nurses than they had in the past. And I would say, if I was going to say, should have been on the major accomplishment page, is one of the things I think that has come out of this program in a much more meaningful way than we expected, was just the enhanced communication and coordination between the hospital, the clinics, and the school nurses and the staff at the schools. We'll talk more in a bit. We've really, like I said, meeting monthly with providers and school nurses in the room. And through that process, not only have we worked out the bugs with our original program, but we have been able to identify some new services that are much needed in the schools, and that we can expand this program to include, one of which, and why we're on the phone today, it has to do specifically with behavioral health. So the one big issue, staff and provider turnover, recruitment, and vacancies, has been a significant issue. And one of our goals for this year is to really make sure our program is developed in a way and has the infrastructure to support these changes, so that they don't derail the program the way that they did the first year especially. So we started this program with two major champions. It was the CEO of the critical access hospital in the community and the superintendent of the school district. And both of those people are no longer in those positions. And so that was a definite challenge in making sure that we kept the lines of communication open and were able to develop new champions to really get behind this program. We also have had turnover in school nurses at several of the schools, and so have had to really be on top of that and make sure that they understand the program, the consent process, and also get the training they need on the system and policies. And we've also had a couple turnovers within the on-site school health center, which is one of the destination sites for this, and so that has also been a challenge in just training and making sure that there's not gaps in services. And actually, one of the things we've done with that is we've added a clinic to the destination site pool. So we originally had two, the John Hughes Student Health Center and Sunnyside Pediatrics, and now we've added Lincoln Valley Family Medicine to that group. And actually, I should say we've added two. We've also added Prosser Urgent Care to that group. So we are able to, as backup providers, so they have access to and training. So if there is a turnover or there happens to be staff not available at either the established clinics, they can be a backup for the school nurses, so that if they do get a student in the program, they don't have to worry about not being able to connect with a provider. And also, yes, we've just had turnover in administrative and support positions as well. And I think the main thing was, again, I think I mentioned this earlier, but an underestimation of just the staff support needed for successful implementation. This is a big change for our providers, both the school nurses and the rural health clinic providers, and also they are already stretched very thin. And so being able to support them and make sure that their time is not wasted and that they can get value out of this program has been important. And we talked about this a little bit before. that we had a historical commitment of a joint effort, and we developed this grant program together. And we definitely thought we could rapidly implement it. Oh my gosh, I'm going to run out of time before I get to a lot of the details. I just looked at my time, so I'll pick it up. Anyway, the buy-in was definitely impacted by a lot of the changes, and we're excited to say, I think, that we've addressed that in a positive way, and we have some great champions on board. I really want to get to the behavioral health issue. One of the things that has come up as we've done this is we've connected more directly with the schools, and we've been able to talk to them about what the needs of the kids are. And so one of the great things we've implemented this year is we have a psychiatrist, a psychiatric nurse practitioner, and a social worker at one of our rural health clinics that now are going to be working with the school counselors at each of the schools to implement a behavioral health program. And this is super exciting to the school counselors, and they are definitely on board. This gives them access for consultation from those providers, as well as allows these students to get their follow-up care that they need. A couple areas that they're focusing on are kids with trauma, which they will originally see, of course, the psychiatrist in their office, but then we'll be able to do those follow-up appointments in combination with the school counselor. And the other one is just on screenings. The school counselors will have an opportunity to have some direct telehealth consults with the behavioral health providers in the community. The other big addition, and then I will wrap up, is that we have added speech and hearing as well. Another great benefit of our program has been, again, hearing from the schools, getting them much more involved with the healthcare system, and the healthcare system much more involved in the healthcare of the children in the schools. And they have now really talked about, there's one speech and hearing provider in all of the county, and so being able to access that speech and hearing provider has been a challenge for the schools and for parents. And so we are now going to be setting them up also to do telehealth. And the great thing about the equipment that we chose is with this virtual waiting room for both psych care and behavioral health care, as well as speech and hearing, it is very easy to do because we have this virtual waiting room, and it doesn't require a lot of extra equipment, and the providers can kind of just jump right in. And so we are working on kicking that process off this month, and we are actually having a big joint meeting next month to go through that process and get those services enhanced in the community as well. So I apologize. I meant to spend much more time on behavioral health, so I'm happy to answer any questions. Sorry about going over time.
No, thank you very much, Lisa. That was all very interesting, and we can get back to you with questions at the end if we have time, but I want to get right to Kathleen and give you an opportunity, Kathleen, to talk about what's going on in Indiana. Need to unmute. Kathleen?
Yep. Hi.
Yep, there you are.
Awesome. Okay. Hello, everyone, and thanks so much for the opportunity to share what we've done in our telehealth clinic so far. Like I said, my name is Kathleen Chelmaniak, and I am with the Indiana Rural Health Association and act as the project director for the Indiana Rural Schools Clinic Network, which we refer to as ERSKIN, which is within IRHA. So unlike many of the others online, we are neither a healthcare provider nor a school, but sort of a third-party provider of these services to our rural partners. Indiana Rural Health Association, or IRHA, is a not-for-profit organization based out of Linton, Indiana, with the mission of improving the health of all Hoosiers in rural settings. And a huge piece of that is access to care. We house one of the telehealth resource centers, the Upper Midwest Telehealth Resource Center within IRHA, so we have a good amount of telehealth experience and knowledge. I have actually been with the organization since 2014, but inherited the school-based telehealth project in early 2018 and have been the project director since that time. I love it, as our main goals are to give kiddos in rural Indiana schools another way to access care within those four walls that they are in every day. So all of this started with a HRSA planning grant that was awarded in 2015. Our intention was to simply lay the groundwork to establish a school-based telehealth network in rural Indiana. We collaborated with a state Medicaid provider, rural healthcare providers, and rural schools in establishing this plan. And while that was happening, HRSA heard that there was going to be a 4-year telehealth network grant program focused specifically on schools. And it was almost as if the stars had completely aligned, and we ended up writing for that 4-year network grant through HRSA Office for the Advancement of Telehealth to get funding for equipment and implementation of these school-based telehealth clinics. As I'm sure it goes without saying, we were awarded that funding and started working towards implementations within that established network in September of 2016. So during this presentation, I'm going to share with you some of our experience with implementing school-based telehealth clinics, our processes. We'll identify why we chose school-based telehealth clinics, who key players are, we'll address challenges, and identify how sustainable these services will be upon the grant period ending. So why telehealth? What was our interest and ultimately our decision to utilize telehealth in schools? First, it goes without saying that there's a shortage of providers in rural communities. I know we've kind of hit on that during this entire presentation. This is a way for us to connect these rural schools to care and give these school-age children easier access to a provider that may or may not be in their physical area. This allows kids to have regular and reliable appointments where they don't have to rely on transportation or scheduling issues, and that speeds up the process of getting an appointment, diagnosis, and potential treatment. On top of that, parents who have hourly jobs or those with jobs that are a good distance away have the option to not have to leave work to be present at the appointment, nor is it on them to get them to an appointment. So their child can have access to care even if the parent is in a circumstance where they can't get them there. Another benefit is that it helps kids establish good health practices. Kids know that if they feel funny or if their ear hurts or if they feel upset or anxious, like from a behavioral health standpoint, that they are able to some degree know that they have access to care through a physical health provider or can talk to a behavioral health provider on a regular basis. All of these services are billed to insurance, just like the visit took place at the physical location of the provider office. To bill, the provider will just have to utilize proper CPT codes and add appropriate GT modifier and place of service codes. And it's also more cost-effective because you don't need a separate provider in the physical school location like some traditional school-based health centers do. And then finally, a huge reason we chose telehealth, as mentioned before, is due to Indiana Rural Health Association housing one of the 12 regional TRCs, telehealth resource centers. So having that experience and expertise within our organization made it easily accessible to vet equipment, identify regulations, and to implement. So let's talk about key players. A critical piece of ensuring success in our school-based telehealth clinics is first identifying your key players and then, of course, getting them all 100% on board. It's truly taken a village to implement these clinics. For success of the clinic, it's been critical to get buy-in from the school, all the way from the superintendent, the principals, to the school nurse, school counselors, and even the teachers. Parents have tended to trust the teachers the most and will ask their opinion on it, so therefore it's critical to make sure teachers understand the telehealth clinic and are supportive. We recently started offering to go to teacher meetings or in-services so they can ask questions about the telehealth clinic and they can feel empowered and comfortable to talk about it with parents. Another key piece is ensuring that the providers are totally on board. We learned it always works better if they're engaged on the front end of the project, especially if they're part of a fairly large provider network. And for our specific project, we wouldn't have been able to do it without the HRSA OAP funding, as telehealth equipment can be costly, and from a staff perspective, we have IRHA to manage all of the working pieces, and that's been critical as the schools and oftentimes the provider in rural Indiana don't have a lot of additional resources to add projects to their plate. We've also received funding from 3 out of the 4 managed care entities in Indiana, and there are a few schools that have community grants to help support their efforts in implementing and expanding the telehealth clinics. In the communities we've been in so far, we do run into families that are uninsured, so we make sure that if the healthcare provider does not have someone to help with this, we have a partnership to provide support and guidance in getting those uninsured individuals signed up for insurance. We ask those navigators to be at back-to-school events, parent-teacher conferences, etc. And then finally, community support is huge. Many of our schools have been great about promoting this via local news, some via Facebook pages, and then others are able to share that via their personal pages, and others promote at community events like fairs. IRHA can and will attend any of these events to help promote the program, and we do attend events at the school to promote it specifically to the school community. So as a member of the Erskine Network, due to grant funds, we are able to purchase telehealth equipment for around 4 new locations per year. And when I say new location, I mean partnership between provider and school. And that's, again, it's dependent on the services they intend to offer. We offer technical assistance, workflow guidance, equipment training, project management, and we can provide checklists to complete key items. We provide templates for consents and legal documentation and can help our network to find billing support and up-to-date information on that. As mentioned before, we promote the program at back-to-school events, family fun nights, and attend events around the state where we will touch rural schools and communities. And then when the clinic is ready to launch, we put on a ribbon cutting with the school and the provider and are able to get TV news, local paper, statewide coverage, all of that. Data collection, we're actually going to talk about in a later slide. And then finally, a benefit of being part of the Erskine Network is having the ability to be part of a network of other school-based telehealth clinics, networking calls, connecting new clinics to established clinics to share experiences and answer any questions. So now we're going to move into the product of all this background, and that is our telehealth clinics. We are currently moving into our 3rd year of funding, and as you can see here, these are our live schools, minus 1 that actually soft launched at the end of August after I had this slide created. And as identified earlier, we are not the provider and we are not a school. We're a rural health organization with an established network of rural providers, schools, managed care entities, etc. So the first step in becoming part of the Erskine Network is for a provider and a school to establish a relationship with intentions to open a telehealth clinic. It will then fill out an application on our website so that we can get some key information from them to determine if they would be a good fit within this grant funding. We work with the established partnerships of local rural schools and providers in Indiana, those who have a full-time school nurse. We tend to work with those with 50% or more free and reduced lunch populations, and then also tend to work with those that have contracts with all 4 Indiana Medicaid providers. As of August 2018, we have launched 8 rural school-based telehealth clinic locations, and that's across the state of Indiana. But we did have to pull equipment from 1 clinic due to lack of utilization, which we'll talk about later in the presentation. So 8 live clinics, 7 which you can see in this figure with the corresponding physical and behavioral health providers on the right-hand side of this chart. The school-based telehealth clinic you don't see is Rising Sun Schools and High Point Health, and their official launch will be at the end of September at their ribbon cutting. By October 2018, we plan to launch 7 more school-based telehealth clinics. 2 out of those 7 will be launching behavioral health at the same time as physical, and an additional 4 by January of 2019, and 2 of those 4 will launch behavioral health at the same time as physical. And we'll get into our physical and behavioral health models in a bit. So I'm going to give you a little bit of data, but just in the form of simple visit numbers. As mentioned earlier in the presentation, data collection is one of the services that we provide through a grant. Previously, we have collected data such as total number of school-based telehealth users by insurance status, age, gender, ethnicity, diagnosis, if the child went home or back to class, and then we do have some customer satisfaction surveys. In the future, we will be collecting more robust data with a tool provided through the grant, which Carlos mentioned earlier, and we're really looking forward to getting some greater detail around school health attendance and the like. If you look at the chart here, I've just provided you with a total number of visits in Grant Year 1 and Grant Year 2. You can see that we almost doubled acute physical health visits from Grant Year 1 to Grant Year 2 and almost tripled behavioral health services from Grant Year 1 to Grant Year 2. And again, this is just with those school-based telehealth clinics that we currently have open. And then you can see total primary care, 310, behavioral health, 98, and then the total visits to date is 408. So before we move into what our workflows look like, I wanted to take a second to identify what telehealth looks like for us. The originating site where the patient is the school, and the distant site is where the provider is. The telehealth solutions we use to connect the schools to a remote provider are web-based platforms with equipment and software installed at the school location. All solutions we utilize in our clinics have attachments that the nurse or the presenter utilizes to access the remote provider's hands. They include a general exam lens, a dermoscope, an otoscope, a stethoscope, which are pictured here on the line between the originating and distant sites. Is someone moving my slides around? Okay. Okay, so current Indiana reimbursement does not give the schools the ability to bill an originating site fee, though if you're in another state, that's something to look into. Indiana Rural Health Association is working to inform legislators of this in hopes that the schools would be able to offset some of the costs of providing care for these kids. Providers, however, are able to bill for this service, and again, in our case, it's still like a normal office visit with the appropriate GT and place of service codes. So we're going to talk about where all of this began, because currently not all of our school-based telehealth clinics offer behavioral health services. We usually start off the majority of our schools with the ability to provide acute physical care, because there is that strong correlation between physical well-being and mental well-being. My husband's actually an assistant principal at a school in Indiana, and he comes home and will tell stories that oftentimes kids are acting out because a physical health need hasn't been met. So the intersection between all of this is so important for overall services in our school-based telehealth clinics. So our initial launch includes services for those acute physical illnesses that are common among school-age children, like flu, strep throat, ear infection, pink eye, lice, rash, etc. So what that physical health process looks like is when a child presents to the school nurse, they will determine if the child would benefit from utilizing the telehealth clinic. This does not take the place of what the school nurse normally does, and he or she will follow their normal workflow for any scratches, rashes, stuffy noses as normal. It's only utilized when the school nurse deems it appropriate and helpful. So for example, if a child presented and was identifying if they had ear pain, the nurse in this case could determine if the child should see a provider. First, the nurse would check to see if there is a consent form on file. They would then call the parent to get a second verbal consent at this time, and the parent can either opt to have their child seen with or without their presence. They then schedule with the provider office, and soon after are able to see the provider at a designated time. The nurse will utilize the telehealth attachment, acting as the provider's hands. In this case, the otoscope would be helpful in the diagnosis of an ear infection. And then after the provider sees everything he or she needs to see, they make a diagnosis, can call in a prescription if necessary. The parent is notified of the results of the visit, and the child is either sent home or back to class. If a prescription is called in, the parent can pick it up at the pharmacy on the way home, and the provider will also send over any necessary information to the child's primary care provider if they aren't already in the same physician network or EHR. In addition to offering acute services, after the clinic is comfortable in its operations, we then move into working with the school to offer an additional service, which we determine with the school. They can offer one or more of these services: behavioral health services, asthma management, diabetes management, weight management, and teledental. Thus far, all have opted to offer behavioral health services to their students, which is telling to the great need for behavioral care, and again, why we chose telehealth for greater access. So we currently have behavioral health services either started or just about to start in 7 schools, utilizing 3 different behavioral health care providers. These providers are fairly close distance-wise to their respective schools. The school and the provider do visits via HIPAA-compliant video conferencing technology. While you could technically do telebehavioral with our physical health equipment, we wanted to make this very cost-effective and easily replicable. So it became apparent that getting a HIPAA-compliant version of a web-based platform our organization utilizes for virtual meetings would work better for the behavioral health visit purposes. It's easy to set up, and the patient will be able to connect via a link from the provider from a laptop that we provide to the school to only be used for behavioral health services. We decided on this technology because we were familiar with it from an organizational standpoint, so there was a little barrier to cost and implementation. It's very easy to add accounts, and it's a paid HIPAA-compliant version of the platform. Each location has their own account to prevent any overlap in appointments, any intercepting of appointments, etc. So this next slide is going to show you our behavioral health providers, and we're currently utilizing 3 entities, but we'll be expanding over the next year. They offer therapy for things like separation anxiety, generalized anxiety disorder, PTSD. As you can see, Aspire is covering 2 schools, Bloomington Meadows is covering 2, and then Family Services of Grant County is covering 1, but soon to be 4 schools. All 3 offer screenings and 2 offer therapy. The one that is not able to offer therapy at this time is due to staff turnover, and they currently don't have the capacity to offer anything but screenings via telehealth, unfortunately. Because of that, we're always looking for more behavioral health providers, and of course those specifically credentialed to practice in Indiana, especially since there has been some legislation passed with goals of suicide awareness and prevention in schools. So this slide's pretty self-explanatory. There's a self-parent or school referral for new patients. The parent can then call the behavioral health provider to request telebehavioral services. The child and parent will then go to the physical behavioral health location, or the behavioral health provider can go to the school to do an initial face-to-face intake assessment. This allows for the provider to determine if telebehavioral is appropriate for a new patient. If deemed appropriate, therapy is then provided via telehealth in a designated private area of the school, and students are given a generic hall pass during non-core classes to go to regular telebehavioral health appointments. As far as we determine who will utilize these services, obviously they look for kids that are comfortable talking to screens. In the technology age, we all have found that oftentimes kids can be even more comfortable talking to screens. I know I personally have heard providers say that sometimes kids open up more via the screens and telebehavioral therapy, and they are still seeing that provider via the video conferencing technology face-to-face. And then providers will also look for those kids with those mid-level behavioral health issues in hopes that they can catch kids here before anything would regress. I should also mention that some behavioral health providers will look through current patient load for patients who frequently miss appointments. That is the easiest place to start because they already have had those face-to-face visits to determine if it would be beneficial, and they also already have consent, so they would just need that additional telehealth consent form from the parent. Challenges, I feel like during this presentation I've heard a lot of similar challenges from the others. So as mentioned earlier in the presentation, we have had 1 full clinic closed due to lack of utilization of the clinic. The reason was due to the lack of a school nurse or a designated healthcare professional in that school clinic. The school looked into hiring a nurse part-time, but logistics didn't end up working out, and clearly you can't predict when a child will become ill, so it was hard to find someone who would fit the bill. And then another challenge is that there is not much in it for the school from a payment perspective in Indiana. While it is sustainable because the provider gets paid for the service, it can make it tough to get school engagement because the school nurse is essentially adding to their already busy day. I have had a few of our schools ask, why would we do this work with, nothing in it for us? And honestly, I get their point, but you always have to come back that it is 100% for the kids. And in the long run, it could keep those habitual users out of the school nurse's office as much due to access to care, diagnosis, and hopefully treatment. And again, as mentioned in an earlier slide, we're working to get it so that schools would be able to bill as an originating site. I am getting a little bit short on time, but I do just want to mention that one of our bigger challenges has been IT. It can take a while because we work with so many different schools and IT departments and providers. It can take a while if the school IT is not experienced. And then additionally, with large hospital systems, you oftentimes have to go through many individuals before you get IT requests approved. This is what has caused some delay in getting our schools connected to providers and then, launched. And so sustainability is our last slide, almost done. So sustainability as far as this grant-funded project goes is huge. To be sustainable in this case, there certainly needs to be buy-in from the school and the provider, which we are so very lucky to have strong buy-in from most of our clinics. I'm confident that they will continue after the ending of the grant. Both the already launched behavioral and physical health models are fairly sustainable for both the school and the healthcare provider. One, because the upfront cost is covered by the grant. We've tossed around ways to make sure the equipment is kept up to date and that those utilizing the equipment can continue to get support and troubleshooting from our telehealth solution vendors. We've landed on a few agreements options between the provider and the school to be able to continue to provide funds toward this. And again, the providers are able to bill for this service, which adds to this sustainability agreement. Again, we already have gotten buy-in from 3 out of our 4 MCEs, managed care entities in Indiana, and have had a few conversations with the 4th and how they can support the program. And we're hoping that in the future we can continue to get their support for the school-based telehealth clinics. Because of the avenue that we've gone with behavioral teletherapy, the upfront costs for that are quite low. So we see it being something that the school and the provider could continue to purchase and implement quite easily after the completion of grant funding. And then finally, this isn't listed, but marketing is a huge piece of sustainability for these school-based telehealth clinics. And the provider or a provider representative should continue to go back to the back-to-school events and other school events to inform parents, answer questions, and just have a provider there to establish trust and buy-in. Okay, so thanks everyone for listening to me talk about what I do every day in rural Indiana schools. I love it. If you have any questions or in Indiana and interested in becoming part of our network, don't hesitate to reach out.
Thank you so much, Kathleen. That was really informative. We have gone about 4 minutes over, so we are not going to take questions at this point, but you have email addresses there on the last slide, and then my email address is on the first slide. So please reach out to any of us with any additional questions you may have that we didn't get a chance to get to today. And this is Shannon Robshaw. Again, I would welcome any feedback that you have directly to me through email, and then please stay around and take the survey. We appreciate it very much. Thanks to all of the presenters. We really appreciate the information you were able to share. Thank you very much. Everybody have a good afternoon.